Hello and welcome to the headquarters of the World Health Organization here in Geneva, Switzerland. I'm Vismita Gupta-Smith and we're live on Facebook and YouTube. We're talking about mental health today, so we will be taking your questions. Don't forget to post your questions on our Facebook Live feed. 10th of October is World Mental Health Day. WHO and partners are urging countries to provide better policies, better access, and quality services to the public. Mental disorders account for 30% of the global disability burden, and yet only 3% of the global investment in health is allocated to mental health. In fact, in some countries in Asia and Africa, this number drops to less than 1%. So why are we not prioritizing mental health? In fact, when you need mental health services, let's say a family, a friend, or you, or a colleague is in need for mental health support, do you know how to recognize the symptoms, early symptoms of mental disorder? Do you know where to seek help? Is help available near you? Is treatment possible? Is it expensive? We'll be taking those questions and more. So keep those questions coming. My first guests are Dr. Shekhar Gupta, Director of the Department of Mental Health and Substance Abuse Department. Welcome, Dr. Shekhar Saxena. Welcome. Excuse me. And Dr. Florence Bengana. You are a psychiatrist from Uganda, but you're working right now for WHO in Sierra Leone. Welcome very much. And Dr. Saxena, I want to start with you. Please describe to us some of the common mental disorders.
Thank you very much. Mental disorders vary a lot and there are many kinds of them. There are common ones like depression and anxiety, which are present in a very large number of people, sometimes not very visible for other people, but there is an internal suffering there. There are also more severe disorders like psychoses and bipolar illness. And finally, there are conditions like psychiatric disorders associated with alcohol or drug use. What they all share in common is an abnormal emotion, thought, or behavior. And that's what characterizes them as being mental disorders.
Now, why are many people who need these services unable to seek these services?
The situation actually is very bad because even in high-income countries with very well-developed healthcare systems, 50% of people with mental disorders never receive any services, which is an extremely unsatisfactory situation. And in some of the developing countries, in low and middle income group, this percentage can be as high as 80 to 90%. Imagine that in this today's world, 80% of people not receiving any help. It's a scandal, and we must do something about it. Yeah. Now coming to why people don't access services, one, because of stigma. Mental disorders are very much stigmatized in all countries. And I must say not only in low and middle income countries, but in high income countries too. And that prevents from people to disclose that they may have a mental disorder and to seek help. The second reason is lack of services. Most countries do not have adequate services. Most countries provide services in far-flung, badly run mental hospitals. And frankly, if I had a mental disorder, I would not like to go there. The third reason is the lack of human resources. The number of psychiatrists, the number of psychiatric nurses, number of other professionals who should be providing help is far too little. There are countries which have one psychiatrist for 1 million population, and that is just not enough. So we are treating mental disorder people very badly, and the blame is for the communities, for countries, and professionals.
So clearly, Dr. Shekhar, the need and the gaps are huge on the ground. How is WHO working with governments to provide better, more accessible mental health services to the public?
Vismita, gap is exactly the right word to use, and that's why WHO has a program which is called MH-GAP for mental health gap. It's the gap between what is needed and what is there, which is huge. WHO's advice and assistance is there for all member states, for the governments to make policies, to make laws, to arrange services which can provide services in the community. We don't want more mental hospitals. We want more community-based services. We want a person who has depression, for example, to be able to go to his or her general doctor, general nurse, to be able to seek help. And we believe that is very much possible. So our attempt is to guide policies, but to also train people so that they can provide the services to people wherever they are.
Now, Dr. Saxena, WHO is also prioritizing and highlighting depression as a theme for World Health Day in 2017. You're launching a campaign about depression. Tell us about that.
World Health Organization has a single day every year, which is on 7th of April, to celebrate one theme out of the whole health area. And I'm very pleased to report that the World Health Organization has decided to devote the 7th April 2017 World Health Day to the theme of depression. And the objective of this theme and this campaign is to see to it that people know about what depression is, how people with depression can be helped, so that they seek help, and also on the government side, they get help. And we hope that this campaign will be participated by millions of people all across the world to make depression a disease which people do not fear but are able to seek help for.
Now, these are some staggering numbers on depression. The number of people with depression and anxiety grew globally from 416 million in 1990 to 615 million in 2013. And now we know that every dollar invested in the treatment of anxiety and depression gives us a return of $4. Then why is it that some of these common disorders like depression are not getting the attention that they need? Dr. Bengana, let me come to you. You have worked extensively in Africa. Please describe to us some of the barriers on the ground that you have seen to people seeking help for depression and anxiety.
Thank you very much. I think some of them Dr. Shekhar has already talked about. One is stigma, of course. Stigma in the policymakers, in the healthcare providers, but stigma also in the patients and their relatives as well. It's also on the side of the patients, their understanding of what the disorder is. So if their understanding makes them believe that it has to do with spirits or it's something they can pray and they get better, then they'll go to the churches and they'll go to traditional healers for treatment. On the side of the healthcare systems, Dr. Shekhar already talked about the numbers, the distribution, the people trained, but we also know about the attitudes of the healthcare workers, and this may also have to do with stigma, but also with the remuneration. So if we train them to take on an additional task, but then we don't pay them for that task that they are taking on. So there are very many different things that are barriers.
You both mentioned stigma, and I remember a very close friend of mine told me years ago that when she was diagnosed with depression, her own family found it very hard to accept that she had depression. They were almost in denial. She first had to deal with her own denial that she had a disorder, and then her family not feeling comfortable admitting it. So let's talk about stigma a little more. When someone comes to you with early symptoms of depression, how can you provide support?
Well, first is to recognize the early symptoms of depression. I think very many people miss them. I can remember also visiting in Afghanistan, a home, when I was when I was doing work there for I went there for a visit, and we asked a husband who insisted on being there with his wife. When we talked to the wife, if the wife is crying and is not eating and is not able to look after her child, what do you think you should do? And he said, we just tell her, pick it up, pull your socks up, just do it. So people don't recognize that feeling bad for an extended period of time, not sleeping, not eating, crying too much, and just not being able to do your everyday work. These are signs of a mental disorder, which could be depression. Yeah.
Now, Dr. Shekhar, are there any groups of people who are at a higher risk of depression?
Yes, indeed. Depression is very common. So in any adult group of people, there will be 3 to 5 people for every 100 who have depression, which is a very high figure. Who are more vulnerable? Generally, depression is found a little more common in women compared to men. It's also more common in middle-aged people and older people, although now we see a lot of young people also having depression. It is more often in people who have suffered a serious crisis in their life. It could be a war, a conflict, a natural disaster, even a personal event, a financial loss, joblessness. They all predispose us to become depressed. And I would just like to specify, as my colleague Florence was saying, depression is a disorder. It's not like we become sad for a day or two. That's different. But when there is sadness, inability to work, crying, pessimistic thoughts, suicidal ideas for more than 2 weeks, it is a real disorder. It's like having a physical disorder. So we should not deny it, we should recognize it, we should seek help, and fortunately, help is available.
And is it expensive to treat this depression?
It's not expensive at all. So, for instance, some of the cheapest medications that are available, it's much cheaper to treat depression than it is to treat hypertension, for instance. So there are medications available, but we also have the listening and helping, the just talking therapies, so what we call cognitive behavior therapy, which is also effective. So one would not need to take medications if one does not need to. But most of this is actually very easily accessible to people, even in low-income countries like those in sub-Saharan Africa.
Now I want to take a few questions from our audiences. My colleague Alison Brunier is tracking your questions. Alison, please continue to be with us. We have some questions for you from our audiences.
Yes, thank you very much, Vismita. There are a lot of questions and comments coming from our followers on Facebook. There's a question here from Tom Gonzalez for Dr. Saxena, and he asks, what is the root cause of mental disorders?
I wish I could answer it in very precise terms. We know that mental disorders have various reasons and causes and risk factors. Some of them are biological. Something goes wrong in the brain and we get a mental disorders. This could be electrical activities, this could be chemical activities. But we also know that environment has a lot of role to play. And as I was explaining earlier, major stresses, sometimes the environment that you live in have a tremendous influence on our psychic functioning, and it can induce mental disorders in some people. There is also a very small amount of element of genetic cause, but I must say that is really very small. By and large, it's biological and psychosocial.
Well, thank you very much, both of you. I know this is a very busy week for you. We have more than 150 partners here, gathered here at the WHO headquarters to deliberate on how to ensure better services for the public. I know you're very busy, so we appreciate you taking the time. Thank you very much. Detecting and treating mental illness is hard enough during normal circumstances. When populations are exposed to high stress, situations like disasters, emergencies, and even accidents, large-scale accidents, these mental disorders become pre-existing disorders, of course, become more aggravated, but we also see an increased number of disorders. How are countries coping with these situations, and what systems are being put in place to provide these services? Here to answer these questions, here with me is Dr. Rabia Al-Shami, Head of National Mental Health Program, Ministry of Public Health in Lebanon. Welcome. And Dr. Mark Van Omeron, Public Mental Health Advisor at WHO's headquarters. Let me start with you, Mark. What are some of the symptoms you witness when a population is exposed to extreme stresses?
When a population is exposed to extreme stresses, like in an emergency, like right now in Haiti after the hurricane, people have many more symptoms than at usual times. So you see more anxiety, you see more sadness, more depression, probably more alcohol use, and even sometimes even more psychosis. Basically all the mental health problems that you would have at normal times, you have more of them in emergencies.
Now, during an emergency, mental health services are disrupted, so it takes a little time to seek mental health care. Is there something called something like first aid for mental health which can be provided, and are countries able to provide that?
Indeed, there is. There's just like in medicine, there's medical first aid. There's also within psychology, there's psychological first aid. And you can imagine right now in Haiti, people will have many emotions, as I was mentioning. They will have many practical problems, and people already can help each other, even when outside services are not yet available. And what can be done is psychological first aid, which involves listening, asking each other asking for what people's needs and concerns are, and helping people getting in touch with basic services.
What are some of the things that governments can do, systems and trainings and support that they can provide to provide the psychological first aid?
Well, the best thing is preparedness. So the best thing is to make sure that in communities, all crisis teams, the police, the firemen, the teachers, all people of key helping roles in the community are already trained in psychological first aid. But that is not enough. Just like in medical first aid is not enough for a health service. Psychological first aid is not enough for mental health care. So the best thing to do is to start developing mental health services now today, so that when something bad happens, services are available on the ground.
Now, Dr. Rabi, Lebanon has more than 1 million refugees, and you have put in place systems which provide mental health care to these refugees. Please share that experience with us.
Well, as a lot of people know, Lebanon has been struggling a lot under the pressure created by the influx of Syrian displaced from the conflict in Syria. In Lebanon, we have more than 1 million, and we are 4 million originally. So the proportion of persons displaced to the population is really high. This has put a lot of pressure on the health system. But at the same time, the momentum of the humanitarian response has generated a lot of interest, and the Ministry of Public Health, in partnership with WHO, with UNICEF, and with International Medical Corps, put together the National Mental Health Program. And the aim of it is to reform the mental health system as a whole. So also, we've seen this in other countries. Sometimes within emergencies, a lot of efforts can go into building back better. And there's a report published by WHO around that. So you can strengthen the system while at the same time providing for the population and also the displaced or refugee community. And Lebanon has went this way. And we're in our third year of implementing this strategy. According to WHO guidelines, I mean, the needs are really high. The suffering is really big, and we're trying to build a system that will be sustainable, that will stay there in Lebanon, because the crisis might last for long, and we know that sometimes funding and support doesn't last as long as crises last.
Dr. Rabi, more than 1 million refugees for a population of 4 million. That is a huge pressure on your health services. Tell us about some of the challenges that you're facing and some of the successes that you've had.
So the sudden increase in number of persons to serve. So we had a sudden increase in 2013, about 30% of the population. In a country that was torn by war, civil war for ages, and where the system in itself was fragmented to start with. But still, the challenges are mainly related right now to be able to answer the needs and to build the infrastructure to provide the best mental health services for the people. Starting from PFA, as Mark was saying, and making sure that we're training the biggest number of responders. So we've been working with frontliners from different NGOs. We've been working also with staff from the emergency rooms, and now we're approaching what might be like the Red Cross who goes to emergencies, going up to integrating mental health into primary care, so making mental health available and close to people where they are, and into building other multidisciplinary teams also in different regions of Lebanon.
I want to go to Alison now, who's tracking some questions from our audiences. Alison?
Yes, thank you very much.
Vismita. Again, there's still a lot of comments coming in. A couple of questions that are probably more appropriate for our next guests, in fact, with two questions relating to the situation in Somalia and what support it's been possible to put in place in a country like Somalia. There was another question from one of our followers in Nepal, the mental health services that are being put in place there. So perhaps we can cover that with our next guest.
Sure. Would you like to talk about some of the experiences of providing psychological first aid in emergencies in situations like Nepal, for instance?
Sure. So in Nepal, Nepal was one of the countries that was where there was some preparedness activities happening before and when the earthquake struck in Nepal. There was benefit from that. So there was a lot of NGOs that were capable of providing psychological first aid, and that certainly helped in the early days of the disaster response. And Nepal preparedness is really something that pays off.
Thank you very much, both of you, for joining us today. We continue to talk about emergencies. We're seeing that emergencies are becoming, certainly natural disasters are becoming more frequent, are becoming protracted, they're lasting longer, resulting in many internally displaced people, large number of refugees with specific needs during emergencies. How are countries coping? Is our emergency response now integrating mental health needs in their routine response to emergencies? Here to talk about that, Dr. Rick Brennan, Director of Emergency Operations at WHO, and Dr. Inka Weisbecker. Inka, you're from the Global Mental Health and you're a Global Mental Health and Psychosocial Advisor at the International Medical Corps. Welcome. Dr. Brennan, I want to start with you. What are some of the conditions, mental health needs that you're noticing in the various emergencies that WHO is working on?
Well, we see mental health problems in all the different types of emergencies that we operate in, from sudden onset disasters such as earthquakes or hurricanes, as we're seeing right now in Haiti, to major outbreaks. Again, as we saw in the Ebola outbreak in West Africa, most recently yellow fever in Angola and Democratic Republic of Congo, and probably mostly in the conflict-related settings. And in all of those types of emergencies, communities and individuals are exposed to great stresses, loss. Sometimes they're exposed to atrocities. They may have lost their families, their other loved ones, their homes, and so on. So there are acute stress reactions. There are anxiety states. There is it can precipitate, these types of events can precipitate depression, sometimes behavioral or social disorders. And of course, we've always got to be concerned about those individuals who have pre-existing mental health problems, and these types of events can exacerbate those as well. In very rare instances, people with no history of mental health problems can have a very, very severe reaction and lead to what's called a psychosis. But generally, most of the reactions are normal reactions to very unusual circumstances, and can be addressed through a series of social interventions and the types of psychological first aid interventions that Mark mentioned earlier.
Now, is our emergency response now incorporating mental health services and psychosocial support?
Not enough, but we are making progress. I think that there's been an increasing recognition in recent years about how important this aspect of our care is. Years ago, we established what are called the SPHERE standards. These are the international standards for the services we provide to populations affected by emergencies. And mental health care is part of the standard of care in emergencies. Unfortunately, we've been slower to integrate that aspect of our care than we would like, but I think we are making progress, and I think that there are some excellent, I think there's the progress we've made on developing this concept of psychological first aid, the work that we've done on understanding how important social supports and access to social services and security giving people information. These all contribute to good mental health in these situations. And I think it's not just the health sector that contributes to mental health, it's those other sectors that we work together with to contribute to people feeling that they have more control over their lives, that they have the right information about how they can access services, and ensuring those general social services are rapidly available. Increasingly, we are training healthcare workers and community health workers in areas such as psychological first aid. I think we've had a number of successes in Guinea after the Ebola crisis. Around a third of Ebola survivors have now actually sought mental health care at primary healthcare facilities with the healthcare workers that we and our partners have trained. And in Syria now, where prior to the conflict, mental health services weren't available really at any primary healthcare facility, about 17% of those facilities now are providing those types of services. So small steps, and we've got a lot of work to do, but I think working with the other sectors, again on the social supports, as well as the health-based interventions, I think we are making progress.
And preparedness. We advocate for and invest in preparedness a lot. I can see Alison has many questions from our audiences for you, Dr. Brennan. Alison?
Yes, thank you, Vismita. So we have a question from Monica Silva, who asks, how are the approaches that WHO recommends adapted to people of different cultures?
Well, I think that cultural sensitivity is clearly very, very important. And particularly as we look at the social supports that are necessary, looking at culturally appropriate ways of organising social services and social supports. Oftentimes what we'll do is organise safe areas for children, bring women's groups together, bringing families that have been separated together. These kinds of interventions are important. And then of course, when we are training healthcare workers, making sure that they are from the affected community as much as possible, making sure that they are attuned to some of the context-specific cultural issues. These are some of the steps that we can take in these types of settings to make sure that we are culturally appropriate.
Before we take other questions from the audience, let me come to you, Dr. Weisbecker. Describe to us some of the supports that you are providing in emergencies on the ground, that organizations like yours are providing.
Yes, thank you. So International Medical Corps is often one of the first organizations on the ground when there's an emergency. And of course, there's always a lot of chaos. There are different organizations, but at the same time, the need is very high. And that includes the need for mental health and psychosocial support. A lot of people, as we heard, are experiencing distress. So one important aspect, first step, is to actually look at the situation in the country and the context and conduct a basic assessment to say, for example, what existed before in the country? What does the healthcare system look like? Are there trained health workers? Are there psychiatrists? Are there psychologists? In Sierra Leone, for example, there's one psychologist, psychiatrist as well, for 5.5 million people, who's national. South Sudan has one psychiatrist, which is not very much. But we can build on these existing systems. We need to look at the guidelines, for example, that are put out by the Ministry of Health. Is mental health included? What should be provided at the general healthcare level so that we can be consistent with these national guidelines? We go to communities that are affected. We ask about general problems. Mental health always comes up. We ask them, with this kind of problem, where do you seek help? Where do people go with this problem? People with, as was mentioned, psychotic disorders, for example, might go to traditional healers. And in emergencies, a lot of the time, people may not have a place to go and have urgent needs. So that's part of the initial assessment. We also coordinate with other agencies. We post our assessments on mhpss.net. We coordinate and co-run coordination groups for other agencies who work in mental health, because we need to make sure there's no overlap, for example, and that organizations follow best practices. Because if many volunteers or others mean well, they go to countries they want to help, but they may not necessarily know global guidelines and how to do things in the best way. So coordination groups for us are a great way to reach organizations with guidelines such as the IASC guidelines on mental health and psychosocial support in emergency settings, which is great for anybody who's interested in that field. Then we of course implement. We train general health care workers, like was mentioned, community health workers, doctors, nurses in mental health. We train psychosocial workers. We work with psychologists and psychiatrists when they exist. We promote social safe spaces and activities for children, youth, and adults, which can then be actually an important entry point as well. We cannot sit in the clinic and wait for people to come. We really have to reach out to the community and link with different service providers to get referrals as well.
Let's take some questions from our audience now.
Yes, thank you, Vismita. So I have another question here. It's not specific to emergency situations. It's more of a general question. Perhaps I can pose this to Dr. Weisbecker. And that's a question from Lionel Idris Sewo, who asks, can depression be treated without taking any drugs?
Yeah, that's a really good question. And there are actually guidelines for the clinical management, as we say, of mental disorders in emergency settings, such as the WHO MHGAP guidelines, which can be downloaded online. And there you see what, for example, general healthcare providers should do when they treat depression. So with depression, of course, first of all, there needs to be an assessment to see if it's really depression or if it's just something like temporary sadness or hopelessness, which can often occur in emergencies. But for depression, I would say, yes, there are actually evidence-based treatments such as cognitive behavioral therapy or interpersonal therapy that have been shown to treat depression successfully. However, there's also some people who are not helped by those interventions enough, and they may need medications. The other problem is that in many countries, those interventions are not available, and then people may also turn to psychotropic medications as well. But there's a lot that can be done actually for depression without medication, but those kinds of interventions and treatments really need to be scaled up.
Thank you very much. I'm afraid we've run out of time. So if you would like more information on mental health, please visit our website, www.who.int. Also, you can find more information on WHO's campaign on depression at that website. Until next time then, stay safe and stay healthy. Bye-bye.